Cord prolapse. It is an abnormal descent of the cord or umbilical cord by the side of the presenting part. It can present in three forms. Occult prolapse. In this, the cord is placed by the side of the presenting part and is not felt by the fingers on internal examination. Then cord presentation. The cord is slipped down below the presenting part and is felt lying in the intact bag of the membranes. Then the cord prolapse. The cord is lying inside the vagina or outside the vulva following the rupture of the membranes. Etiology of cord prolapse is malpresentation, contracted pelvis, prematurity, twins, hydramnios, placental factors can be present or iatrogenic factors can be there. Then the diagnosis of these cord prolapse is done. If the cord is presented there within the intact membranes, then the diagnosis can be made by feeling the pulsation of the cord through the intact membranes. If it is occult, then it is difficult to to diagnose the prolapse, but the variable deceleration of fetal heart pattern can detect the occult prolapse. If the cord prolapse is there, then it can be seen through the vulva or the vagina to diagnose the cord prolapse. Now the management of cord prolapse is proceeded as to see if the baby is live or dead, or see for the maturity of the baby or the cervical dilatation, how much the cervical dilatation is there. If the baby is alive, then the immediate vaginal delivery is contraindicated as it is not possible in the patient. And then if the immediate if there is no immediate vaginal delivery is done, then the definitive management in these patients are the cesarean section. In these patients, the first aid which is taken is the postural treatment is done. Then lift the presenting part of the cord and replace the cord into the vagina, and then proceed for the cesarean section. Then if the baby is alive and immediate safe vaginal delivery is done or is taken as a chance, then the vertex or forceps delivery is done. With the help of forceps delivery it is done. If the patient is dead, baby is dead, if the baby inside the uterus is dead, then confirm it first with the USG, then wait for the spontaneous labor. If patient goes into the spontaneous labor, then the delivery is done by own. Then if it is not there, then the destructive operation is done and the baby is delivered.